Hello, everybody. I would like to welcome you back. Our next session is going to be with Dr. Rachel Gafni and Dr. Kelly Rosczko. They both come to us from the NIH in Bethesda, Maryland. And their topic today is regarding calcilytics, Encalaret, and ADH1. Thank you both for coming.
Hello, can you hear me?
Yes.
Wait, hi everyone. Just gonna share a screen. Here we go. Well, thank you so much for having us here to speak today. We are very excited to talk to all of you. I am going to start out by speaking a bit about autosomal dominant hypocalcemia type 1, including the natural history of the disease. And then Dr. Gafni is going to follow up with our new data on Encalaret treatment. And these are our disclosures. So as an outline today, I'm first going to speak a little bit about normal parathyroid gland function, just to remind everyone. And then we're going to speak about what is ADH1. And then I'm going to tell you a bit about the characteristics of ADH1 patients, including conventional treatments and complications that can be specific to ADH1 patients. So, oh, sorry, my mouse is lost. So here we go. The parathyroid glands are 4 small glands found on the back of the thyroid in the neck, and they are very important because they make parathyroid hormone. The main function of parathyroid hormone, or PTH, is to increase blood calcium. So when your body detects a low calcium, the parathyroid glands release PTH hormone, and that in turn increases the calcium back into the normal range. It does this in 3 main ways. First of all, PTH releases calcium from the bone. The bone is a big storage repository for calcium. So PTH allows this stored calcium to be released when you need it most to increase your blood calcium so that it remains in that normal range. The second thing that PTH does is it acts as the kidneys to hold on to calcium and prevent any calcium from being lost in the urine. And finally, PTH also acts as the kidney to promote the activation of vitamin D to form calcitriol. And calcitriol is that activated form of vitamin D. Active vitamin D increases the intestine's ability to absorb calcium from the food. So taken together, PTH allows you to use what calcium you already have stored. It prevents more calcium loss in the urine, and it increases your ability to get more calcium. All of this taken together results in a higher blood calcium. So how does the parathyroid sense calcium? It does this through the calcium sensing receptor, or the CASR. And this is a picture of the calcium sensing receptor. It's a G protein coupled receptor. We call it that because it has this G protein that sends the signal from the receptor inside the cell. So before we go any further, let's just review the calcium sensing receptor. This is what it looks like. It's a very long protein with 3 main parts. The part outside the cell is called the extracellular domain, and this is going to detect the amount of calcium present. Then there's a transmembrane domain, and this means it crosses the cell membrane 7 times. And finally, there's this part inside the cell, which, as I said, can signal to other proteins in the cell. And this is what's going to ultimately tell the cell how to respond to that calcium level. So the calcium sensing receptor is located on many cells throughout the body, but we are going to focus on the parathyroid and kidney cells, where it is located in much higher numbers. On the parathyroid cells, it senses that low calcium and in response increases PTH release. So we're going to discuss the kidneys more later, but there it senses a high calcium in the blood and it signals the release of that calcium into the urine. So the calcium sensing receptor tells the parathyroid cell here when to make PTH and when to not make PTH. So sort of like a little machine here that's making PTH and putting it out into the bloodstream. And it's noting that the calcium is kept in a very narrow range. So very tightly regulated, we call that. So the calcium sensing receptor is sort of like a thermostat. There's, an area where there's too little and too much calcium. And then there's a set point where it's happy to keep the calcium right, sort of in a good range. And as we all know, having too little or too much calcium is very bad. So we want to keep it in this range and specifically around that set point. So let's talk about the calcium sensing receptor a little like a thermostat. So when the thermostat in your home detects a cold temperature, it tells the heater to turn on and heat up the house. Very similarly, when the calcium sensing receptor detects a low calcium, it tells the parathyroid cells to make more PTH, and that PTH is then going to act inside the body to increase the calcium, and that brings you back to the normal range. So it's very much like a thermostat. So when there's low calcium in the blood, the calcium sensing receptor is turned down and the PTH is released into the blood. And the calcium sensing receptor is essentially telling the parathyroids too little calcium, so make this PTH. And the converse, when the blood calcium gets too high, the opposite happens. The calcium sensing receptor is activated and PTH production decreases to ultimately decrease that blood calcium level. And here the calcium sensing receptor is telling the parathyroids there's too much calcium here, so just stop making parathyroid hormone. And we don't get those effects. So the calcium sensing receptor is also found in the kidney. Similarly to the parathyroid gland, when the calcium is high, the calcium sensing receptor tells the kidney to get rid of calcium by putting it out in the urine. So you get an increase in urine calcium. So now that we have some background about the parathyroid gland and how the calcium sensing receptor works, I want to go into what is ADH1. So autosomal dominant hypocalcemia type 1, or ADH1, is a rare type of genetic hypoparathyroidism. Its prevalence is about 1 in 70,000 people. And there's a change in the calcium sensing receptor, which causes it to be stuck in that activated state. Therefore, the body is tricked into thinking that the blood level of calcium is higher than it really is. So using our thermostat analogy, let's imagine that it's freezing in your house and the thermostat is broken. So even though it's freezing, the thermostat is telling you that it's 80 degrees and therefore it's not turning on the heater and the house is remaining cold. So similarly in ADH1, because this activating mutation is in the calcium sensing receptor, even though the blood calcium is low here, the receptor is telling the parathyroids that the calcium level is high, and therefore PTH is not produced, resulting in a lower blood calcium level, even though it is already too low. So in the kidney, the calcium sensing receptors are also affected. As a result, the kidney thinks the calcium level is high, and it excretes even more calcium into the urine. Thus, these patients with ADH1 have inappropriately increased calcium in the urine, even though their blood calcium is actually low. So in ADH1, the calcium sensing receptor is signaling that there's plenty of calcium around, but in reality, the findings are that the blood calcium is low, the parathyroid hormone is low, the blood phosphate is high, and the urine calcium can actually be high. Sorry, there we go. So to summarize, in ADH1, the thermostat is broken. The ADH1 set point is wrong because the receptor is too active. The calcium sensing receptor is signaling that there's too much calcium, but there's really not enough, and therefore PTH is not released. And these are just some important things to remember, that ADH1 patients have develops parathyroid glands from birth. The parathyroid glands are capable of making normal PTH, and there is no destruction of the parathyroid glands throughout their life. So these are really normal glands, that these parathyroid glands are just receiving the wrong signal. Okay, and finally, I'm going to shift gears a little bit here, and I'd like to talk about the characteristics of ADH1 patients. I'm also going to talk about some conventional treatments that have been used and complications that are specific to ADH1 itself. So now that we've talked about ADH1, I'm going to tell you about some of the gaps in knowledge and a study that we did to learn more about this disease. So first, as I said, ADH1 is a rare disease, which means that there are many case reports that describe a single patient, or many case series, which talk about just a handful of patients. But there are not many very large studies that describe the disease in general. So we set out to sort of tie this data together, and we aimed to pull cases out of the literature so that we could combine them together and make conclusions about a greater number of patients with ADH1. So we did this literature search, and it was a large search with several search terms. We looked for autosomal dominant hypocalcemia, ADH1, genetic or congenital hypoparathyroidism, familial hypoparathyroidism, hypercalciuric hypocalcemia, activating calcium sensing receptor variants. So we looked for just a wide variety of terms to make sure that we didn't miss any of these cases. And we looked at a date range from 1996 up to 2021. And then we kind of went through each study and collected data from each study to put it together. And this search actually brought us to 70 papers that we could compile data to look at the patients that they describe. So in our study, we have 183 patients who had information about the symptom onset of ADH1, when they got their symptoms and how that was diagnosed. We had 90 patients who actually had initial laboratory values that were published in the papers, and 58 patients who had information about the outcomes after their treatment that we could put together to learn more about treatment and outcomes. So first, let's discuss the findings on symptom onset and diagnosis. So the first thing I'll talk about is inheritance. So 78% of these cases were familial. That means that they were inherited from an affected parent here. ADH1 is inherited in an autosomal dominant manner. Autosomal means that it's carried on one of the regular chromosomes. So this is not the X or the Y, which are called the sex-determining chromosomes, but one of the regular chromosomes. And dominant means that if you have the variant, you can show the disease. And it doesn't matter what gene you got from the other parent. So of course, as we'll see, not everyone shows the disease as severely as other people who have that gene. But what it does mean is that every time a child is born to someone with ADH1, there is a 50% chance that that child will also be affected with ADH1. And you can see here about a 50% chance that you would have the affected gene coming from that parent. So 19 of our patients were found to have de novo mutations. A de novo mutation means that the person's parents do not have that variant in their DNA. It's a new variation that developed just in that person, sometime just before or after conception. The person's siblings, therefore, are not at risk of having ADH1. However, now, this person has an autosomal dominant variant, and that can be passed down to their children by the 50% rule that we just discussed. So this would be this picture. Parents are not affected, siblings are not affected, but this one person has a de novo variant in their DNA. And finally, 3% of the inheritance is neither of these or unknown from that literature search. So I put this up just so we could look a little bit closer at the calcium sensing receptor. I know we've spoken about it quite a bit, but this is a real close molecular view. So the calcium sensing receptor protein is actually made up of 1,078 little tiny building blocks. And these blocks are called amino acids. A change in one of these amino acids can cause the receptor to be too active. And that, again, is what leads to ADH1. That means the calcium sensing receptor is telling the cell that there is not enough calcium and PTH is not released. So in the diagram here, you can see there's some red and black stars, and these are showing areas of activating variants. Additionally, interestingly, there are inactivating variants of the calcium sensing receptor also, and these are shown in the picture by the green stars. So these patients have the opposite of ADH1. They actually have high PTH levels and higher calcium levels and low urinary calcium levels. So this is a different disease altogether called FHH. So it's interesting how you can see that there are many places that these variants occur, really all over the receptor. And that's why I put up this diagram for you, that you could really see how many different variants there are and the breadth of how they can be really anywhere throughout that receptor. In some places, a change can cause the calcium sensing receptor to have a substitution, and that could even change, whether it's activating or inactivating. I bring this up because some patients who are on this call right now with ADH1 might actually know what their specific variant is. And that can be really helpful if you are looking to trace this illness through family members, because you can look specifically at that area in this really large gene to see if a family member has that variant or not. So in our study, we found that 54% of these variants are actually in the extracellular or outside the cell domain. We had found 33% in the transmembrane domain, which is this one that crosses the cell membrane, and 13% in the intracellular domain, or this inside the cell part. So other than 7 variants, which were very severe, we found that in general, which variant a person has does not actually change how severe or mild their ADH1 behaves. And in fact, in some families, we've seen siblings who have the same variant in their DNA, but one is much more severely affected than the other. And we aren't really sure why this is the case. So I think as more studies go on, we will hopefully learn more about this illness. So now, let's talk about how did most people get diagnosed with ADH1? Well, 70% of the patients that we saw throughout this literature search were diagnosed because they developed symptoms. And despite 78% of the cases being familial, only 24% of cases were identified through family screening. So it was interesting to find out. And I think this could be for a few reasons. For instance, sometimes a parent could be discovered after the child. And I think it's important to note that this could also be because parents might be diagnosed with idiopathic hypoparathyroidism, which means hypoparathyroidism that they don't know the cause of. And perhaps the doctor is not, screening their children. It's not thought to be a genetic thing. And then it's found to be in the child later. So they're presenting with symptoms. I think our findings of 78% of these cases being familial should actually prompt some increased screening and genetic diagnosis and testing of those with idiopathic hypoparathyroidism, as knowledge of one of these genetic disorders could really help diagnose a child and reduce the risk of presenting with a severe symptom, such as a seizure. And finally, 6% of the diagnoses were due to an incidental findings. Incidental finding means that the patient had blood drawn for another purpose or for just routine screening, and then it was found that their calcium was low. So these patients didn't have any symptoms or problems. They were just sort of found to have a low calcium, and when it was worked up by their doctor, found to have hypoparathyroidism. So next, I'll discuss the age of diagnosis, and this actually varied widely. So the diagnosis of hypocalcemia in general ranged from birth all the way to age 66, with a median age of diagnosis of age 6, and that's of hypocalcemia. The diagnosis of ADH1 itself was even further delayed, with an age range of birth to age 77 and a median age of 25 years. So as you can see, many of these patients were not diagnosed until much later in life. And this is very likely because, as you'll see in these coming slides, the disease varies greatly between individuals. So this chart shows the presenting symptoms of the patients. And as you can see, 27% were asymptomatic, meaning they had no hypocalcemia related symptoms at all. 33% had moderate symptoms. We classified moderate symptoms as muscle cramps and spasms, bone and joint pain, tetany, paresthesias, brain fog, and fatigue. 39% of the patients presented with severe symptoms, and these included seizure, loss of consciousness, and laryngospasm. Of note, the most frequent initial symptom presentation was seizure. That was in 38% of our patients. And it's a very severe symptom and can be life-threatening. So I think really what we've found from this literature search is that we need to strive to diagnose these patients before they have these severe presentations. So the median age of diagnosis varied significantly, with severe cases being diagnosed at a median of 1.3 years of age, but other cases at a median of 14 years. So you can see that, again, the severity really does matter as far as age of diagnosis goes. These are the initial calcium levels from 90 patients who had calcium values reported in the literature. And not surprisingly, calcium was significantly lower in severe ADH1 cases than in the moderate or the asymptomatic cases. And in fact, you can see sort of this step down here, with the highest calcium being in the asymptomatic patients, and then the moderate patients, and then the lowest calcium levels here in these severely affected patients. So we looked at the percentage of patients with each laboratory finding and found that on initial studies, 99% of the patients did have low blood calcium. 59% had high blood phosphate levels, and 59% had a low blood PTH. But of note, these are instances that PTH was defined as low in the study and reported as that in literature. However, for many of these people that are not represented here, my guess is that their PTH was likely inappropriately low and so not able to maintain the blood calcium. And importantly, you can see that 35% of patients had high urine calcium on their initial studies, and that is frankly elevated urine calcium levels. So when discussing urine calcium, I want to bring up this study by Yamamoto, which looked at initial urine calcium levels in patients with idiopathic hypoparathyroidism or with ADH1. So the first two groups here, 1 and 2, are patients with idiopathic hypoparathyroidism due to an unknown cause. And as you can see, their urine calcium values are mostly low or in that low normal range. However, these next two groups here, 3 and 4, are 9 patients with ADH1. And you can see that their urinary calcium values tend to be in the upper part of normal or even frankly high. Importantly, these values were measured before patients were even started on treatment. So their blood calcium levels are still in that low range with hypocalcemia and hypoparathyroidism, but their urine values are quite inappropriately elevated. And that's, as we said, because of that calcium sensing receptor working in the kidney. So here we show data from 58 patients who had reported treatment for ADH1. As you can see, the majority of patients, 56%, were treated with active vitamin D only. 42% were prescribed both calcium and activated vitamin D, and 2% were prescribed only calcium. Unfortunately, I don't have data about the treatment outcomes for each of these specific groups, but we were able to summarize treatment outcomes for the whole group, which I'll present here. So the average blood calcium of the treated patients increased by 24% to an average blood calcium of 8.1 milligrams per deciliter. This is right below the reference range, that normal range. 23% of the patients had blood calcium measurements on treatment that actually were in the normal range. Now, it's important to remember that we often have a goal of keeping that calcium just below the normal range, or in the low normal range, to prevent those urinary calcium effects and that urine calcium from increasing. And we'll talk more about that next. Of the 34 patients who reported the effects of their treatment, 24 or 69% of them reported improvement of symptoms while on the treatment. So what I thought here, it's really important to note that 31% of these patients didn't have symptom improvement, even though they were on treatment. And I think this emphasizes how our current standard of care is often not adequate to control the symptoms of ADH1. So this next graph shows the urine calcium and the serum calcium in 7 patients. These are patients with idiopathic hypoparathyroidism, not ADH1. And they're all treated with either 1,25-dihydroxyvitamin D, which is calcitriol, the active form. Those patients are the solid lines, or vitamin D, calcitriol plus calcium. Those patients are the dashed lines here. And you can see this is their urine calcium going up on the y-axis and their blood calcium here on the x-axis. So as you can see, their urine calcium levels go up quite a bit with increasing blood calcium levels. Well, we want blood calcium levels to go up to help alleviate patient symptoms. We're very concerned when we see the urine calcium levels climbing like this. And here you can see that in our review of ADH1 patients, the same pattern was seen. The cases of hypercalciuria, or high urine calcium, increased significantly when patients were being treated. So you can see that 34% of the patients had high urine calcium before treatment, but after treatment, 66% of patients had high urine calcium levels. Of note, these are frankly high and not even looking at patients who have that high normal range, which we also would be concerned about. So why is the urine calcium so important? Well, we're very concerned over complications, particularly kidney calcifications. There are 2 different types of kidney calcifications that we look at, and one of them is kidney stones. This is also called nephrolithiasis. They're stones that are located in the tubes where the urine flows, and they can block the urine, causing pain and sometimes require a procedure such as lithotripsy to break up those stones. This is a diagram of the kidney stones, and you can see that the stones are here in the tubes where the urine is collected, or actually in this ureter, which is the big tube that's going to bring the urine down to the bladder. The second type of kidney calcification is nephrocalcinosis, and this describes the calcification that occurs in the kidney tissue itself. The top 3 circles here show areas where you would find nephrocalcinosis, and the bottom circle is where that urine is collected and would be nephrolithiasis. So in our survey of cases in the literature, we categorize the complication as kidney stones, nephrocalcinosis, kidney or renal insufficiency, and brain calcifications. Of note, while we can see these brain calcifications on CT scan, we have no reason to think that they cause a clinical problem to patients at this point. So our literature search found that there were complications in 76% of the total ADH1 patients who underwent treatment. Of note, there were complications in 47% of those who had a urine calcium that remained in the normal range, but there were complications in 88% of patients who had high urine calcium levels or hypercalciuria. So this shows how the high urine calcium is likely related to those increased complications. And it shows us how important it is to keep the urine calcium controlled in our patients. Sorry, sometimes these slides are not advancing. There we go. So for complications and to avoid them, in hypoparathyroid patients, the urine calcium should be monitored, especially while on treatment, and especially in ADH1 patients, even more so than regular hypoparathyroid patients. The high urine calcium can be associated with a greater chance of complication, specifically kidney and brain calcifications. So in summary for what we've talked about so far, the majority of ADH1 patients have a variant in a gene that is inherited from a parent. And in most cases, ADH1 is diagnosed because of symptoms. ADH1 patients have a wide spectrum of symptoms. They can go from asymptomatic to severe and even present with seizures. ADH1 can be diagnosed early in childhood or late in adulthood, and that's likely because of this wide spectrum of symptoms across patients. And the average calcium levels are lower in patients with more severe initial symptoms. And treatment only cured symptoms in 69% of the patients. And importantly, the urine calcium tended to increase while those patients were on treatment. Patients with high urine calcium levels generally had more complications than in patients with normal urine calcium. And therefore, in conclusion, ADH1 patients could benefit from novel therapies, especially if they don't increase the urine calcium. And with that, I am going to turn it over to Dr. Gafni, who's going to tell us about some of the exciting new therapies.
Thank you. Let's see if this works. Uh-oh. Hold on one second. Because I didn't test this. I just got a new computer. Oh, I'm gonna have to quit and leave the meeting and come. I'm gonna be right back. Maybe, why don't you answer some questions, Kelly?
Okay, Dr. Rosczko, can you hear me?
Yes.
Okay, sorry about that. I wasn't prepared to.
Oh, no,
to
that's
step
fine.
in.
I mean, we can also just wait a second. I'm sure she'll be right back. So
No, we do
is
have one
best for-
question if you want to try to answer this. It's a fairly
Great.
simple one. It says, if I am post-surgical, is there a higher chance of my baby getting a genetic hypopara?
No, that's great news. There is not. If you are post-surgical, there is not a higher chance of your baby having to worry about that at all. So that is good news. That it shouldn't be an issue.
Okay.
Okay.
Do we have Rachel back in now?
She's here.
I literally got a new computer yesterday and everything's been working great, but I hadn't set up the permissions for Zoom to access my PowerPoint. So, but you can all see that now? You can see my PowerPoint? Okay, great. All right, well, let's keep talking about this. Thank you so much for having me. I wish we were in person. I remember when this meeting was in person. It was always so much fun, but I think a lot more people are able to participate this way. So I guess that's good. All right, so oops. Here are my disclosures. So I'm not going to go into a lot of detail on conventional treatment because you've heard about this from Dr. Rosczko and Dr. Khan. But of course, conventional treatment for ADH involves calcium in multiple divided doses during the day, high dose vitamin D and or calcitriol or alpha calcidol. And some patients also need extra magnesium because the calcium sensing receptor and PTH are important for magnesium handling. And treatment, of course, is problematic because we have to target the blood calcium below the normal range or right at it, which can still result in symptoms. And treatment increases the urine calcium, which can result in calcium deposits in the kidney. And Dr. Rosczko just described this exact same graph in detail, so I'm not going to go over it again. But the bottom line is when you have ADH or other types of hypoparathyroidism, when you take calcium and calcitriol, the urine calcium goes even higher. So for ADH patients who are starting already at inappropriately high urine calcium levels, this gets worse. So when we're trying to manage ADH1, we're walking this treatment tightrope. We're trying to keep the blood calcium up high enough to not have symptoms, while at the same time keeping the urine calcium down. So there are some additional strategies to try to reduce urine calcium, which I recommend for all patients with hypoparathyroidism. One is to drink a lot of water. And while that doesn't decrease the milligram amount of calcium in the urine, it will decrease the concentration of calcium in the urine so that it may be less likely to deposit because it'll be able to flow through. Reducing your salt intake can help reduce your urine calcium because salt pulls calcium into the urine. And when you eat a lot of salt, you get sodium in your urine, and calcium and sodium walk out of into the urine hand in hand. And then some people will use thiazide diuretics like hydrochlorothiazide or chlorthalidone to decrease urine calcium. But these drugs have not been well studied in hypoparathyroidism or ADH1, and they can cause other electrolyte problems. So if you are taking those, they have to be monitored closely. So what about using PTH in ADH1? And Dr. Khan went through this in detail, the PTH 1 to 34, which is teriparatide, and PTH 1 to 84, or intact PTH. And these both 1 to 34 in Esforteo for osteoporosis and Natpara for hypoparathyroidism have been marketed, and TransCon PTH is under investigation. But the truth is that PTH therapy is not well studied in ADH. Really, PTH has only been studied in small groups of people with ADH. And this has been both by intermittent injections and continuous infusion pump. But in fact, patients with ADH were specifically excluded from the large studies that led to FDA approval of PTH for hypoparathyroidism. And I believe in the phase 3 TransCon study that Dr. Khan presented, only 1 or 2 patients with calcium sensing receptors causing ADH1 were included in that study. So somebody had asked in the earlier talk, do you need to get genetic testing to be prescribed PTH, when in fact, really the studies were done primarily in patients with post-surgical hypoparathyroidism and other genetic causes. Patients with other genetic causes were in some of those studies, but not ADH. And intermittent injections, based on what we know, can manage the blood calcium, but do not completely normalize 24-hour patterns and can have unintended effects on the kidney and the bone. And this makes sense. This graph shows the PTH production over the course of the day, over a 24-hour period, by people without hypoparathyroidism. And that big gray shaded area is showing the normal range, which actually goes a little bit higher than they are showing on the y-axis. So these people without hypoparathyroidism are maintaining PTH levels within the normal range over the 24-hour period, but there is a little bit of a peak early in the morning where you see the PTH levels go up. And in contrast, this is a graph showing what happens to PTH levels when you take an injection of PTH 1 to 84. And now that gray box normal range is all the way down here in the bottom. And you see that the PTH level goes very, very high right after the injection, and then gradually comes down, but stays high for several hours, 6 to 8 hours. It's still above the normal range. So this is not really mimicking normal physiology with taking an injection of PTH 1 to 84 once a day. And in our study of PTH 1 to 34, this is a kidney ultrasound of a 40-year-old patient who had ADH1, who actually didn't have any nephrocalcinosis before he was on PTH, but after 1 year of PTH twice daily, this is PTH 1 to 34, he did develop nephrocalcinosis, and you can see this these abnormal white deposits that the arrow's pointing to in the kidney ultrasound. Now, the longest experience of a patient with ADH1 receiving PTH 1 to 34 therapy was published here in 2009. This was at that time a 20-year-old woman with ADH1 who was treated for 14 years continuously with twice daily injections of PTH 1 to 34. And despite this treatment, her urine calcium remained elevated And while she didn't have nephrocalcinosis when she was a young child, she still developed extensive calcium deposits in her kidney by age 19, despite being on PTH therapy. Her bone turnover was higher than normal, and the spine and hip bone density was very increased with this PTH treatment. And her forearm bone density was decreased. So remember, PTH has these differing effects on the skeleton. That's why PTH is also used to treat osteoporosis, because some types of bone, it increases the bone density, and other types of bone, it decreases the bone density. And this is the head CT of that patient. This is her skull at 18 years of age. And the white is the skull. And you can see that it's very thickened, and it has some dark marks, which are like little punches where there's less bone, and then white areas where there's more bone. And just to compare, this is the head CT of an adult patient also with ADH1 who was not treated with PTH. And you can see that the skull is much more uniform without those white spots and those black spots, showing that the bone turnover is not normal. So this may be a result of these intermittent injections of PTH that don't mimic normal physiology, but maybe longer acting PTH, such as TransCon PTH, will better replicate the typical 24-hour profile. But remember, PTH therapy won't affect the overactive receptor in the kidneys of patients with ADH1. So while PTH may be useful for the skeleton and maintaining the blood levels, it's not going to fix the whole problem in patients with ADH1. So better treatments for ADH are needed. And this is a timeline of just parathyroid discovery. And the parathyroid glands were first identified in animals in the late 1800s. And it was almost 100 years ago when a doctor in Canada gave a parathyroid extract to a dog without parathyroids and showed that it would correct severe seizures and muscle spasms. And then PTH was isolated, and in the 90s, we started using it at NIH in hypoparathyroidism. It was approved in 2002 for osteoporosis. And then, of course, I think you all know the story of the PTH 1 to 84 approval in 2015, which was soon after removed from the market in the United States. But what about the calcium sensing receptor? This was identified in 1992, now 30 years ago. And in 1994, a couple years later, it was discovered that variants in this receptor cause ADH. And in 2000, calcilytics were developed as a class of drugs. So now we're talking 22 years ago. So what's a calcilytic? And Dr. Khan gave you a brief introduction to it, so I'm going to tell you a little bit more. So calcilytics are a class of drugs that turn down the calcium sensing receptor. They basically reset that thermostat that Dr. Rosczko was explaining so nicely. They make the parathyroids and the kidney less sensitive to the blood calcium level. And as a result, when the receptor is less sensitive and it thinks that there's less calcium around, this causes increased PTH secretion and less calcium lost in the urine, with the goal of increasing the blood calcium level back to normal. It was originally developed as a potential therapy for osteoporosis, because remember, PTH therapy is used in for your osteoporosis in people who do not have hypoparathyroidism. And you can imagine that there was a lot of interest for that, because while there aren't a lot of people with ADH and hypoparathyroidism, there are a lot of people with osteoporosis. So this was a really good incentive to develop a class of drugs. But what happened was, when they gave it to over 1,200 postmenopausal women, they did see an increase in blood calcium and PTH, but it didn't help with the osteoporosis. But on the plus side, it had a good safety profile. So our studies are a repurposing of these existing drugs. So again, calcilytics turn down the calcium sensing receptor, and they promote the production of PTH. So when you have this calcilytic to reset the thermostat, PTH is now produced by these normal parathyroid glands that have just been getting the wrong signal. Likewise, in the kidney, you have this activated calcium sensing receptor, and when you treat it with a calcilytic, now it corrects this faulty signal, and you can decrease this urine calcium that's being lost. So there have been studies in animal models in mice that have variants in the calcium sensing receptor. So they have what looks like ADH, and they were treated with calcilytics and had improvement in blood calcium and decrease in urine calcium. So that led us to do the first calcilytic study in humans back in 2014, 2015. And we had 5 patients with ADH1 who were given daily 3.5-hour infusions of a calcilytic called SHP635. It was also called NSP795 in increasing doses. And they were not on any calcium or calcitriol. And our main questions were, will it increase the PTH levels? Will it increase the blood calcium levels? And will it decrease the urine calcium? And what we saw was there was a statistically significant increase in PTH levels when the patient was receiving the infusion. And you can see as soon as the infusion was stopped, the PTH level drops right back down. Unfortunately, the exposure was so brief that the blood calcium level didn't change, but we did see a trend in the decrease in urine calcium while patients were on the infusion. So the next step was to treat patients with higher doses for a longer duration and ideally with an oral medication. So that brings us to the study that we are working on right now, and this is a phase 2b study looking specifically at Encalaret, which is an oral investigational calcilytic. And I presented some of the early results a year ago, but we have a lot more results to share with you now. This was a phase 2b study design divided into 4 parts. Period 1 involved 6 patients who were admitted to the hospital for 5 days for individualized dose escalation, and I presented that to you last year. Period 2, those same 6 patients with another 7 patients were admitted to the hospital for for 5 days, and they had individualized dose titration. And then all 13 patients went into a 24-week outpatient phase. And these results were presented at the Endocrine Society meeting in June and the ASBMR meeting in September. And now the patients are in a long-term extension phase. So for these visits, they came for a screening visit to assess their eligibility and had blood work, urine, kidney ultrasound, and a bone density study. Then period 1 I described was this 5-day overnight stay where they got once or twice a day increasing doses of Encalaret, and they had very frequent blood and urine sampling. They sometimes 18 times a day we were checking blood samples. Oops. Period 2, they came back, and again, we were adjusting the doses to try to figure out the dose a little bit better. And then period 3 was this 24-week home treatment, and they came back to the NIH every 8 weeks for 24 hours of frequent sampling. And now they're in the long-term extension, coming to NIH every 6 months and otherwise living their lives. Our main goals were to assess the safety of the drug, and to determine the best dose that will increase and stabilize the PTH, increase and stabilize the blood calcium, decrease the urinary calcium, decrease and stabilize the blood phosphorus, and increase and stabilize the blood magnesium. So what are the risks? Well, the risk of this drug is increasing calcium and PTH levels, but that's what we want it to do. Of course, if the drug didn't work, patients could develop hypocalcemia. So we monitored patients very closely, and we also made sure that they were getting at least 1,000 milligrams per day of dietary calcium. But in the osteoporosis studies, there were no other specific safety signal or adverse events identified. So we were really felt pretty reassured that this drug was going to be fairly safe. So these are the baseline characteristics of our patients, we had 13 patients at a mean age of 39. So they were all adults. The youngest were 22, and 8 of the 13 were women. And their blood calcium and PTH levels were, not surprisingly, very low at baseline, a calcium of 7 and a PTH of 6. Phosphate levels were high normal and magnesium levels were low normal. And the 24-hour urine calcium was elevated with a mean value of 384. And about 3/4 of the patients had nephrocalcinosis. Kidney function was variable in the group, but with some having low kidney function and others having normal kidney function. They were all on calcium and calcitriol in pretty typical doses throughout the day, and their genetic testing showed 9 different calcium sensing receptor variants. So this I showed you last year, and these are the Encalaret levels with these increasing doses over the 5 days in period 1. And you can see that on the first 3 days where we gave it once a day, the Encalaret doses came back to very low levels, but on the last 2 days, when it was 180 milligrams twice a day, we were able to maintain levels in the bloodstream the whole time. The PTH levels mirrored these rises in blood Encalaret levels. You can see on day 1, a very low PTH level bumping up a little bit, but by the time we were getting into days 2, 3, 4, and 5, the PTH levels were staying well within the normal range or even slightly above on those days. This is the dosing for the Encalaret, and this is period 2 where we were really individualizing the doses for the patients. On day 1, we started patients on fairly set doses, but what we realized over the course of the 5 days was that the dose requirement was so different between patients, so that by day 5, some patients only needed 10 milligrams twice a day, while other patients needed 180 milligrams twice a day. So we really needed to individualize it for each patient, just like you do with thyroid hormone or insulin or a lot of other medications. But what was interesting was once they got into that period 3, 24-week outpatient dose period, and each line here is one of the 13 patients, there were a few adjustments we still need to make during the first 4 weeks, but after that, the dose actually stayed fairly stable for most of the patients during the 24 weeks. So what happened to their blood calcium and PTH levels? I'm going to show you a bunch of graphs, and most of them are very similar. The graph on the left is the period 2, which is those 5 days of inpatient where we're adjusting the dose every day. And then the period 3 is the graph on the right where they're coming to NIH every 8 weeks, but they're otherwise taking the drug at home. So you can see the blood calcium levels in the top panel started very low prior to receiving Encalaret, but was into the normal range by the 2nd day of that inpatient phase in period 2. And they stayed within the normal range during the 24-week outpatient period in period 3. And similarly, at the bottom, PTH levels rose with the Encalaret, bounced around a little bit, but you can see in period 3 on the right bottom that the PTH levels were staying normal in the patients. And when we looked at the sampling, when we did 24-hour sampling on a single day, and the patients were admitted to NIH in week 24 of period 3, and we drew their blood multiple times a day over 24 hours, you can see that the blood calcium level on the left panel stayed really flat. It was really very stable without a lot of spikes and drops. And the PTH on the right also stayed within the normal range. So here we're seeing PTH stay normal, not seeing these giant spikes like we saw in the one where you were given the injection of PTH. So this seems to be more physiologic. What about 24-hour urine calcium? We see here that Encalaret decreased the mean urine calcium from a high level at baseline into the normal range, which is really exciting. So not only were we correcting the low blood calcium, but also the urine calcium came down. And we didn't see any progression of renal calcifications on ultrasound at week 24, but of course, we're continuing to follow this in the long-term extension. Encalaret decreased mean blood phosphate. And you can see here that the phosphate levels in the period 3 on the second half are staying in the mid-normal range. And this is because, remember, parathyroid hormone is needed to excrete phosphorus, which patients with hypoparathyroidism have difficulty doing. So with the increase in PTH, they were able to excrete blood phosphorus, and the tubular reabsorption of phosphate came down during period 2, but then stabilized during period 3. Magnesium levels shown in the top also increased into the mid-normal range, as did the calcitriol level, which is also called the 125 dihydroxyvitamin D. So the patients weren't taking any calcitriol, but their bodies were better able to make it. Now, remember, hypoparathyroidism is a state of low bone turnover because PTH is necessary to both stimulate bone breakdown and stimulate bone formation. So we saw increases in bone turnover markers in patients while they were taking Encalaret, but for the most part, they stayed within the normal range. There were only 3 patients who still had high bone turnover markers, and we're continuing to follow that. We did bone density studies, DEXA scans, to look at the effects of Encalaret. And we found that at least comparing the screening DEXA score to the 24-week period 3 DEXA score, we didn't really see significant changes, except maybe a slight decrease in the total hip. And these numbers that we're looking at are called Z-scores. And Z-scores are the score of it's a standard deviation score comparing you to other people your same age and sex. So a normal Z-score is between -2 and +2, and an average Z-score is 0. So if you have average bone density, your Z-score is 0. And you can see at the screening, which is typical for hypoparathyroidism, that the Z-scores are a little bit higher than 2 for most sites, except for the distal radius, the forearm. And that's because most people with hypoparathyroidism typically have high bone density. So what about side effects? Encalaret was well tolerated with no serious adverse events. The only treatment-related adverse events we saw were some mild hypophosphatemia and hypercalcemia, where the blood phosphate level was a little bit low and the blood calcium level went a little bit high while we were adjusting the dose. But these were transient, asymptomatic, and corrected once we got the right dose. So it's very exciting. We're still doing that study, but what's next? So the study that I showed you is a phase 2 study, but now we need to move into a phase 3 study. And this study is called Calibrate. And the goal of this study, ultimately, what we're hoping for is that this would lead to FDA approval of the drug. So this is an international, multi-center, randomized, open-label, 2-arm study that should be hopefully opening sometime in the next few months. Patients would be screened. They have to be at least 16 years of age and have ADH1. And then we're trying to enroll about 45 patients at all of the sites around the world. They'll be monitored on their calcium and calcitriol for about 4 weeks, and then they'll be randomized. And 2/3 of the people will be randomized into receiving Encalaret, while 1/3 will be randomized into continuing on the calcium and calcitriol. And that's for about 20 weeks, where the doses are adjusted. And then they'll continue on their maintenance doses that have been figured out during the adjustment period for another 4 weeks. So it's 24 weeks where you're randomized to either Encalaret or calcium and calcitriol. And then after that, everybody will continue on Encalaret. So the 15 patients that were on the conventional therapy group will eventually switch over to Encalaret, and they will be followed for up to another 180 weeks. So this is very exciting. NIH will be a site for this, but there will be other sites around the United States and in Europe, and I think maybe Japan. I'm not 100% sure. So definitely keep your eye out for it. But what about other forms of hypoparathyroidism? ADH1 is a really rare form, and most people with hypoparathyroidism have post-surgical hypoparathyroidism. So the question is, could you give Encalaret to a patient with post-surgical hypoparathyroidism to decrease the urine calcium and increase the blood calcium? Because patients with post-surgical hypoparathyroidism have normal functioning calcium sensing receptors in their kidney, but you could still trick it so that maybe the urine calcium wouldn't be so high. And some patients with post-surgical hypoparathyroidism have some remaining parathyroid cells, so maybe giving Encalaret would stimulate those remaining cells to make more PTH. And we don't know the answer to these questions. So what we're planning on embarking, and this is going to be led by Iris Hartley, who's one of our investigators at the NIH, is a 1-week inpatient study at the NIH Clinical Center, including 15 patients with post-surgical hypoparathyroidism. So this isn't a treatment study. This is a 1-week study to try to see, is it possible? Would this drug maybe work? And if it does, then perhaps we would be able to go on to do a longer treatment study. So this is a very exciting thing that we're embarking on. So, of course, we're talking about adults with ADH, adults with post-surgical hypoparathyroidism, but we all know, and I'm a pediatrician, that trials in children and pregnant women are also needed. So in conclusion, activating changes in the calcium sensing receptor cause a rare form of hypoparathyroidism called autosomal dominant hypocalcemia type 1. Conventional treatment of ADH1 does not address the underlying problem, and PTH therapy has not been well studied in ADH1 and doesn't affect the altered sensing by the calcium sensing receptor in ADH1. Calcilytics are drugs that turn down the calcium sensing receptor and may become an effective oral therapy for patients with ADH1. And the effect of a calcilytic in post-surgical hypoparathyroidism is unknown, but is an area of future study. And this is our great group at the NIH, still masked here most of the time, but we are trying to get together a little bit more and enjoy each other's company when possible. And so there may be patients watching who are participating in our studies, and we thank you so much for your dedication to helping us learn more and hopefully develop better treatments. And with this, I think Dr. Rosczko and I can take some questions.
Okay, thank you very much for that information. Let me get you some questions here. The first one is, for peri or postmenopausal women, has a decrease or increase in Encalaret been observed?
Well, I can tell you that we didn't have to change the doses. So over the course of, for example, that 24-week outpatient period, and we have patients who are in their 20s, women in their 20s and women in their 60s, so postmenopausal, and we didn't specifically look at perimenopausal women, but we weren't finding that we had to adjust doses. For example, in the young women, when they would get their period, sometimes historically, some patients with hypoparathyroidism will say that they need more calcium around the time of their period, or when they go into menopause, they need less calcium. We were not seeing those types of adjustments, and patients were not reporting that to us, but we weren't systematically studying the effects of menopause or periods on Encalaret requirements.
Okay, and then has there been an increase? Oh wait, that's actually, you just answered that. That was about menses. Is there increase of use of Encalaret while on menses? The next question is, has there been evidence of kidney healing with Encalaret therapy?
Yeah, we and Dr. Rosczko is going to be presenting the data at the American Society for Nephrology meeting next month. So what we can say so far, and remember, the patients haven't been on the drug that long. We're presenting out to 24 weeks. We haven't seen any worsening of kidney ultrasounds. So that's good. And there hasn't been a statistically significant change in mean eGFR, which is that kidney function number that I showed you. So we haven't seen worsening, but it might be too soon to see if there's an improvement. But, and that's part of why the phase 3 study, you have that control group with the people on conventional therapy, because you need to see, will those patients, if you see kidney function continuing to go down in those patients and stabilize in the Encalaret patients, that might be a suggestion that it's having an effect on kidney function, but we're certainly not seeing a decline.
Okay. Someone wants to know, you just discussed that you had an ADH1 patient that was on PTH therapy for a long time. But do you not recommend that ADH1 patients try PTH therapy?
It's really hard to know. I think that it may be, and of course this is all off-label use because ADH patients were not included in clinical trials. It seems certainly more physiologic to consider these long-acting products or continuous infusion therapy. And there was a publication last year in the New England Journal by a group in England showing that they were able to decrease seizure frequency in 6 children and young adults with ADH1, that they were having difficulty managing them with calcium and calcitriol, and they put them on continuous PTH through an infusion pump and had fewer seizures. They were able to come off their seizure medication. They were having fewer visits to the emergency room. I think that the once or twice daily PTH injections are, we're not sure if it's doing more harm than good. So the question is, particularly in somebody with a genetic disorder that maybe you're going to start this patient in childhood, what's your long-term plan? Would you keep them on that for 80 years? We really don't have that kind of safety information. I think maybe using it in the short term, if you're really having difficulty managing them, but once or twice a day certainly doesn't mimic physiology and potentially could really do some unusual things to the skeleton, like that skull that I showed you.
Okay. And then regarding Encalaret for the surgical patients, if a patient had still 2 parathyroids left, but they are just functioning suboptimally, would they be a candidate for Encalaret?
Yeah, there will be screening criteria, and PTH level there will be sort of a cutoff screening. So there will be patients who will be more severely PTH deficient than other patients. I can't tell you what the exact criteria for that will be, but if you're interested in the study, and it hasn't gone live yet and it's not posted on clinicaltrials.gov, we're still in the sort of regulatory phase of getting that approved. There will be a contact through clinicaltrials.gov, and we will give the Hypoparathyroidism Association that information to post on the website. And you could contact us, and we would assess your eligibility over the phone to start before you even made the first trip here.
Okay. And someone wants to know when the surgical study happens, will they be required to come to NIH, and how long is the study expected to last?
Yeah, it's a 1-week study. So it's a 1-week inpatient study. So you would come you'd have a screening. I'm not sure if it's a separate screening visit. There might be a separate screening visit and then a return. And then once it's determined you're eligible, then you would come and be an inpatient for 1 week. And that would be the only time you would get the medication, would be during those 5 days of the inpatient week. And then you'd go home and you'd get follow-up labs. So it's not a treatment study. it's what they call a proof of principle study to get a sense, would it work at all? And if that 1 week study shows some information that this might be effective, then this is like what we did with the first study with the calcilytic, where we did 5 patients just as an inpatient for 1 week and said, oh, it looks like it might work. And then we went on to do the longer study.
Okay, I'm sure that there are going to be people that want to know if they participate in that first part of the study and then it was found that it does work, would they be eligible to continue on in further studies?
Yeah, absolutely. Participating in that study would not exclude you from any other studies. I mean, you'd still, anytime there's a new study, there's new inclusion and exclusion criteria, and you need to meet those criteria to be in that study. Chances are, if you met the criteria for the first study, you would meet the criteria for the second study, but there's no guarantees, you know. But yes, it wouldn't exclude you from being in anything.
Okay, and we have one more question. Do you suspect urine calcium will drop after just 1 week of Encalaret in the post-surgical patients?
Well, I can tell you that there's a study in mice that have had their parathyroids removed that were given a calcilytic, and they did have a decrease in urine calcium. So if people behave at all like a mouse, then I would hope to see that decrease. Yes, but there's never any guarantees. That's why we do the research. And we really appreciate all of you who come out, especially people who come to NIH from really far away to be in our studies, because we've learned so much. And I think we've made a lot of progress because of people like you guys who participate in research. And so thank you.
Okay, well, that is going to end it for the questions for now. We appreciate you and Dr. Rosczko participating with us today. We look forward to hearing more about your research in the future. And I just want to let everybody in the community know that we are going to take a quick 10-minute break, and we'll report back in 10 minutes for the next session. And thank you guys, ladies, again.